Here, we all nurses, we all know what are the nursing issues, what are the basic nursing care and all. So this is some sort of a refresh that you have to refresh your knowledge, and also you understand that palliative care is not only for the patients, it's for the family. And also the thing is, within the hospital, we are there, we nurses and doctors are there to take care of the patients. When they go home, who will take care of the patient? So now, obviously, the caregiver will take care of the patient now. Okay. So that is why we sit here and learn how to teach the caregivers for taking care of the bed-bound patients. So I'm sharing my screen. Can you able to see my slides?
Yes, ma'am.
Okay, thank you. So what are what is the basic principles of caring for a bed-bound patients? We all know that if you give a proper care for a bed-bound patients, we can able to prevent their healthcare complications. So what are the healthcare complications that can occur for a bed-bound patients? Any idea? Imagine a bed-bound patients. Okay, Salome said ulcers. What kind of ulcers they will get?
Depression, ma'am. Depression is there. Bed sores.
Bed sores, definitely. If you are not take care of the bed-bound patients, that especially skin, if you are not giving proper skin care to the patients, that patients might be developing bed sore. Then, as Pooja said, depression, because of isolation, they can develop depressions. Then contractures, if they are not, the immobility can cause contractures, and also a lot many problems if they have a immobility, not taking adequate exercise, or not then if because of the bed bound, they will develop constipation and all so many problems will be there. So as you already said, there are a lot of problems might be developed for a bed-bound patients if you are not taking care of them well, because bed sore, contractures, depression, and other problems too. So if we are giving proper care to the bed-bound patients, we can able to prevent healthcare complications, as you were mentioned earlier. Then we can also promote their comfort level also. So the thing is, we understand that the major aim of palliative care is to improve the quality of life of the patient and their family, and also we can able to improve the promote the comfort level of the patients. So and then the third one is build confidence. So we can able to build their confidence level, because and they, when they go home, they don't know how to take care of the patient, the bedbound patients. We are the person to teach the caregivers and make them understand well, and they can. So if they are understand well, they will get a confidence. So in front of you, they will demonstrate you. For example, for a nasogastric tube feeding. In the hospital, we nurses are there. We will take care of them. We will give feed every 2 to 4 hours if they want. Based on their need, we will give the food feeds and all. But the thing is, when they go home, they has to the caregiver has to be feed for that loved one. So within the hospital, we can teach the caregivers, and in front of us, they will show it once again, then they will get the confidence. Okay, so we can able to build confidence level, and we can able to prevent isolations. For example, if you give, when they go home, if you give a, if you provide home care to that patients, somehow we can able to prevent isolation level 2. Somebody goes there and talk to them, and also if you develop a community participation, like if you develop volunteers in that particular the community, so that volunteers will go there and talk to the patients, that especially bedbound patients, they are not able to come out from the room. So that way we can able to prevent isolation from that patient. And if you give these all things, definitely we can able to improve the quality of life of the patient and their family. So these are the principles of caring for a bedbound patient. So let's see what are the basic needs of the patients. We all know that what are the basic needs: oral care, skin care, eye care, ear, nose care, hair, perineal care, nail. These are the basic needs. For a normal persons, we all know how to do that, whatever we can. So we ask our needs, as per our needs, we are able to meet our needs. Okay. Imagine a bedbound patients who are not able to take care of their daily things. Um, they want to take that daily needs, the daily things. They want to meet their daily needs, but they are not able to get up the bed. So that is why we need to take care of the patient and as well as family. So let's see one by one. Oral care. So we all know that oral care is very, very important things, because 90% of systemic diseases are linked with an oral care. So if you are not giving proper care on the oral cavity, so it can cause too many problems. So oral care is equal to, if your oral care is improved, definitely the oral health is also improved. So what are the purpose? Can anyone say what are the purpose of oral care? What are the objectives of oral care? So you can unmute yourself and talk, or you can put your answers in the chat box. Any idea? We all nurses, you can unmute yourself and talk. We have a small group. No worry. Mahima said we can promote good oral hygiene. Salome said prevention of infections. Good. Rekha said increase appetite. Again, Sheeba said to prevent from infection. Any other answers? Monica, we are waiting for your answers.
To prevent from bad breath.
Sorry?
To prevent from bad breath, ma'am.
We can't hear you. Your voice was not clear. Okay, let's see one by one. So thank you for your contributions. We all know that mouth is an excellent incubator for growth of bacteria, because there is a chance of food particles left in the mouth. If you are not giving proper mouth care to the patients, there is a chance of growth of bacteria. That way, the infections will be there. So if we are giving proper mouth care, we can able to prevent infection. Then the thing is, we can able to maintain healthy status of the mouth, teeth, gums, and lips. So, and the first and most important, the purpose is our main aim is to remove food particles from that mouth after eating. That as we discussed earlier, there is a chance of growth of bacteria. There is a chance of food particles left in the mouth, it can that can cause infection. So if you give mouth care, we can able to remove that kind of things from the mouth. And the second thing is to keep the lips and mucosa soft, clean, and intact and moist. So the third one is promote comfort. We can able to promote comfort if you are giving proper mouth care. And the next thing is we can able to improve the nutritional status of the patients, and that way we can able to stimulate their appetite level too, and blood circulations. If you give a proper mouth care, definitely we can able to improve the blood circulation of the oral cavity and eliminates the source of unpleasant odor and prevent dental caries. These. So these are the things which the major purpose of oral care. So then now we move on to the common oral problems. What are the common oral problems which you have seen in your settings? Candidiasis, gum disease, bad odor. Okay, thank you. There are lot of problems in loose dentures. Okay, there are problems. So these are the dry mouth, painful mouth, halitosis, candidiasis, oral mucositis, alteration in taste. So these are the common oral problems which we have seen in palliative care. So dry mouth, halitosis, candidiasis, oral mucositis, alteration in taste and excessive salivation. So let's see one by one. The first one is xerostonia, dry mouth. If the patient is having dry mouth, so it like to be this, you can see that you have seen in the screen. So it look like this. So and the next one is one of you have mentioned earlier, candidiasis. So if they have a candidiasis there, it look like this. Okay. So if they have a problem like this, they are not able, sometimes they will complaining of not able to swallow properly. So that time you have to check whether they have a oral the candidiasis. So if there is a the candidiasis could be extended to the, sometimes it could be extended to the esophagus too. So that time the patient is not able to swallow properly. So you have to check for that. And the next thing is halitosis. So halitosis is also another problem. And the next one is mucositis. So mostly when you have seen is after chemotherapy and the radiotherapy, some of the patients, most of the, not some of them, most of the patients will develop mucositis. So next we move on to the needs of mouth care. We all know that every person needs mouth care. As a normal, the normal persons, we need to maintain at least twice a day oral hygiene, morning and evening, morning and night after food. So we have to maintain dental the oral hygiene like that way. But so I have a question. So what kind of patients need a frequent mouth care than a normal person?
Patient in ICU
Very
who are
good.
bedridden.
ICU in the sense for a bedbound unconscious patient?
Ma'am, who are bedridden.
What
Bedridden
do
patient.
bedbound patient? Yes, need. Okay. Bedbound patients need mouth care, but that patient needs frequent mouth care. Do you think that patient that for a bedbound patient needs frequent mouth care? Even if the patient is conscious?
Yes, ma'am.
How often you give?
at least once a day.
Yeah, twice a day is must, not must. Not once a day. Twice a day is must. But I am asking you, who that what group of patients need mouth care more frequently than a normal persons? Unconscious patients, okay, who cannot spit and swallow. Then any other answers? We all nurses. Please share your thoughts. Okay. Terminally ill patients. In the sense, terminally ill means the patient is unconscious. Sometimes the bedbound patient, they are not able to meet their daily needs. And unconscious patients, patient breathing through the mouth, because an unconscious patient, most of the time they will be breathing through the mouth, so that can cause dry mouth. So that patient needs frequent mouth care at least every 4 hours early. And post-operative patients, so that patient is also need frequent mouth care. Patient with infection sign, diseases of mouth, so that you can imagine a patient with CHE or head and neck cancers. So foul smell and pus and all inside the mouth can cause lot of problems and lot of irritations too, lot bad smell and all other problems will develop. So that kind of patients need frequent mouth care. And the last one is patient on nasogastric tube feeding. Usually the patients who are on nasogastric feed often neglected their mouths. Nobody is take care of their mouth. So that patient is also need a frequent mouth care. Whenever you give a nasogastric feed to the patients, you have to, at that time you can give a mouth care to that patient. That way we can able to improve the blood circulation to the gums. And if the blood circulation improve, definitely the other problems will reduce. So coming to the assessment, whenever we see bedbound patients, you have to check whether they have a cracked lips, dry or cotton tongue. If they have a dry or cotton tongue, there might be candidiasis. You have to check for that. And white curd-like patches, it look like a candidiasis. And so if there is a white curd-like patches there, you have seen that picture. It looked like a word curd-like patches like thing. So if you have seen this kind of thing, you have to ask them that they have to swallow it properly. The food, if they most of the time they will be telling like I'm not able to swallow food because of some pain. Will be whenever I swallow anything, I am experiencing pains, something like that. So and also you have to assess ulcers. Is there any ulcers in the mouth, any redness or bleeding, any pain in the mouth? So how will you assess the pain? So we all know how to assess pain. You don't assume. You have to ask the patients whether they have pain or not. Pain is we also learned about pain is what the patient says first. So whenever the patients having any ulcers in the mouth, you should ask whether they have a pain or not. And dysphagia and any change in taste of food, any difficulty in chewing, because if they have a dryness there, dry mouth there, they will not be able to chew properly. So if they are telling like they are not able to chew properly, then you can assess is there any dry mouth there. And also anorexia, unpleasant smell, medication history and treatment history. This is very, very important, because most of the medications which we have used in palliative care, that can cause dry mouth. So you have to go through the medication history. If they have complaining of dry mouth like things, you have to go through their medication history and also treatment history. As I mentioned earlier, if they have a stomatitis or other problems like that on candidiasis and painful mouth, like that they will tell, they will, you have to ask the treatment history also. So next, coming to the mouth care part, now we have learned the common oral problems, why we are giving what proper mouth care to the patients, and who needs mouth care frequently, and how will you assess mouth oral cavity. And now we move on to the caring part. So what solution is good for mouth care?
Sodium
Chlorhexidine
chloride.
solution. So, do you use mouth this chlorhexidine for mouth care? This is a mouth washes, right? So, I am asking you about how to what solution you can use for mouth care. So you can use normal saline or water. The water is the good agent for mouth care, but for a bud patients, it may not help well. So you can take homemade saline or normal saline. In a hospital, we have a normal saline, but when they go home, they are not able to buy normal saline. Sometimes they are not, they have don't have much money to buy that normal saline bottle. So you can teach the caregivers about how to make homemade saline. We already learned. You can either you can use sodium chloride solution, or you can use soda bicarb solution. If you take if you advise them to make homemade saline, then you can take 500 ml of water and add 1 teaspoon of common salt and boil it, cool it, and that solution they can use for mouth care. And if there is lot of the halitosis, like bad smell coming out, you can suggest soda bicarb solution. So if they are taking soda bicarb, preparing soda bicarb solution, they can take 500 ml of water and add 1/4 teaspoon of baking soda. So same thing, boil it and then cool it. So after that, they can use these solutions for mouth care. And whenever you see a patient, sometimes a bed-bound patient who is not able to do their mouth care, able to manage their mouth care on, they need a help, but they are conscious. So that patients, that type of patients, you have to give a self-care education, as we discussed earlier. So, but brush the teeth twice a day. This is very, very important. That way we can able to prevent infection. And toothpaste. If they are using toothpaste, so they have to make sure that there is no toothpaste left in the mouth. If there is a toothpaste left in the mouth, that can cause dryness. So you have to tell them that, and rinse the mouth with homemade saline or soda bicarb solution after that eating. So after every meal, they have to clean with homemade saline or soda bicarb solution. And tongue also they can clean with toothbrush. Ask them to take plenty of oral fluids, so that way we can able to improve their hydration. We can able to maintain their hydration level. And pineapple. So if they have a dry mouth, complaining of dry mouth, you can advise the patient to take a pineapple thin layer, because the thing is, that pineapple contains an enzyme called anise. So the thing is, this is acidic. If they have ulcers, any ulcers in the oral cavity, that might have some problem, because it will irritate the ulcers, and that patients develop pain. So if they are not no ulcer, if they are not having any ulcers in the mouth, only in the dry mouth is the problem, then you can suggest these kind of things. So if they are using tenders, that should be removed at night and replaced in the morning. So coming to the procedure part, now if the patient is requiring assistance, this is how we teach the caregivers. If they are able to do their, for example, if they are able to do their daily things like imagine if paraplegic patients, they are not able to walk, but their upper limbs are able to move. So our aim is, our thing is arrange. So we need to empower the caregivers. Our role is to arrange all the articles nearby and encourage the patient to do the mouth care, his or her own. So because that way we can able to improve their muscular that muscles that strength and all. So here you can see that picture. You can arrange all articles nearby and encourage the patient to the mouth care. So as we all know that always you have to explain the procedure, provide privacy, and provide semi-Fowler's position or Fowler's position. You can give a comfortable position to the patients. Always try to prevent soiling of their own dress. You can give a protect their dress with a towel. And you can pour water in the brush and you can place a dentifrice on it, and you can give to the patients and encourage the patient to the mouth care. So these all we know. The thing is, I have seen many patients here. Once the patient is become bedbound, like a paraplegic patient, the caregivers will pay all the problem, all the things. The caregivers will be there for helping all the things. They will the patient sitting alone, they're sitting freely, and if they are able to do something, then but the caregivers doesn't allow to take care of. Now you can keep, you can be there. I'll give all the care, something like that. So that way, the thing is, if you do like that, their muscle muscle wasting will be there. So they are not able to do maybe later on. They are not able to meet their things. Even then, if they want to take a glass of water in their the upper limbs, they are not. If their their muscles are not in a good position, they are not able to lift up that a glass of, at least a glass of water too. So whenever you see these type of patients, you have to educate the caregivers first. Whatever they can, they have to do it their own. You have to give a good support to the patient and encourage the patient to do the basic needs as much as they can. And then coming to the terminally ill patients, you imagine a patient you are taking care in the hospital. So maybe tomorrow you are going to just imagine an unconscious patient. The caregivers want to take that patient in his home. When they go home, how will they take care of the patient? So especially we are learning on oral care. So for a bedbound patient, unconscious, not a bedbound patient, unconscious patient, when they go home, who will take care of the patient mouth? Obviously, we all know that the caregivers will be going to take care of the mouth. So how will they how will do the mouth care for an unconscious patient? Any idea? Think about from the home care settings, rural area. They are tomorrow they are going to, the patient is go, the patient and the family, the caregiver is going home, will be going home or maybe sometimes they are not affordable for the hospital cost and all. So they will maybe they will request you to, I want to go home. My wife is taking care of me. So tomorrow I want to go home. So just think about for an unconscious patient, how the caregiver will take care of the mouth. Do you give active forces to the caregiver? How many of you agree with that? Any answers? Do you provide active forces to the caregivers? And no. Rekha said no. 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 Then how will you not possible? How will you educate the caregivers about taking care of the mouth? Any idea? No. So we never thought like that. No, we once we send them to home, send back to their home. So we never thought like that. Okay, how they will manage in their home. But when we are in palliative care, we will think about how to do oral care for an unconscious patient, is even into the home care settings. One of you, Saloni said wooden spatula. Okay. So how will you use wooden spatula? Okay, let's see one by one. In a hospital settings, we have artery forceps and tongue depressors. Artery forceps for cleaning and tongue depressors for opening the mouth. But without tongue depressors, we can't. We are not able to open their mouth because they always close the mouth. So whenever we need to open the mouth, we use tongue depressor for opening the mouth for an unconscious patient. But in home care settings, we don't have an artery forceps. Even if you give an artery forceps, the caregivers doesn't know how to close it, how to open it. So we are the nurses. We have a skill. We all know that how to open it and how to hold, close it and all. So in home care settings, we can use home spoon or ice cream sticks. And in hospital, we have a gauze piece. In the home care settings, if they don't have a gauze piece, they can use clean cotton cloth and normal saline. We in the hospital we have a normal saline, but in home care we can ask them to prepare homemade saline and small Macintosh. If they don't have a small Macintosh, they can use plastic sheet. Our idea is only we need to protect the bed. Bed and bed cloth and all, so that things we need only the plastic knit. If they don't have a Macintosh, we can use plastic sheets and face towel. Obviously, we all patient house at least one towel will be there. They can you can use that, and clean water, and again clean water is also there. Soft sticks, so you can use soft sticks for applying moisturizing agents. So these are the articles needed for mouth care for an unconscious patients, even in the hospital settings and home care settings. So you have seen that picture, one spoon, there you can take a spoon, the handle of the spoon you can wrap with the gauze piece, the cotton cloth or a gauze roll. So procedure, we all know that how to take care of an unconscious patient mouth. We can keep a small, always protect the bed with the Macintosh, educate, explain the procedure to the patient, provide privacy, provide semi-folders position, and we need 2 spoons, one for opening the mouth and another for cleaning the mouth. One wrapped spoon you can keep it in the tray for opening the mouth, and the another spoon you can take for cleaning the mouth. Okay. So and you have seen that picture. Whenever you take care of the patient mouth for an especially in unconscious patients, first you have to now open the mouth and check the oral cavity whether the patient is having any problem. So then if they have any problem there, you can treat the problem after mouth care. You have to, when they after oral care, you have to document it if, whether they have any oral problems like that. Then you can start cleaning with normal saline first, and then the same side you can clean with plain water. Otherwise, the normal saline taste will be there. So that will be quite distressing to the patient. So after cleaning with normal saline, you have to clean with normal saline. That way we can able to subside the taste of the normal saline taste. So when you have to wrap the hand, you can wrap the handle of this spoon and soak the wrapped cotton roll into the normal saline, squeeze out of excess water. So why we need to squeeze out excess water? For an unconscious patient, this is very, very important, but the caregivers don't know. If they if you are not teaching well, they will soak the cotton ball, and right away they'll going insert that part into the mouth, and that water enters into the larynx, and that way the patients develop aspiration. Okay, so whenever you after soaking, you have to squeeze out the excess water, then you have to clean the mouth. First you can clean the lower chewing surface and inner side, outer side, then upper chewing surface also the same way, inner side, outer side, and the surface, the chewing surface. This way we can able to clean the mouth and clean the oral cavity from proximal to distal. Okay, I'll show you a video on how to do the mouth care, then you will get a good idea about that. And after cleaning with cleaning with normal saline, you have to clean the oral cavity with normal water. Okay, and after that you have to lubricate the lips with the using the swab sticks, and whenever any lubricating agents you can use, like this liquid paraffin, coconut oil, ghee oil, Vaseline, anything. So if they have a liquid paraffin or ghee oil, Vaseline, if they don't have anything, you can apply coconut oil. So our idea is moisturizing the lips. So now we can watch a video on how to do the oral care for an unconscious patient and
comfortable position to the patient. Take home messages. Mouth care is an important part of daily patient care to prevent infections and foul odor. Remember to keep the patient's head tilted to one side during the mouth care. Do not use your fingers to open patient's mouth. Squeeze off excess water from the gauze before doing mouth care. Clean the mouth with clean water at the end of mouth care. To know how to make homemade saline, watch the video Dressing Materials and Solutions. Mouth care in an unconscious patient. Mrs.
Any doubts regarding oral care? Any clarification or any things you want to add or anything? No. No. So I hope that the presentation is clear to everyone, and the video was helpful to understand well. Let's share my screen again. Okay. So next we move on to the next thing, care of eyes. So here you have seen in infected eyes and then non-infected eye. One eye is infected and the another one is non-infected. Which eye you will clean first? Clean eye. Salome said clean eye. Okay. Clean. Okay, very good. So we all know that we have to clean the clean eye first. But the caregiver doesn't know which one which eye is clean first and which eye is clean second. So we have to educate the caregivers about these things. So they have to clean the cleanest eye first, then go to the infected eyes. Before they are doing the eye care, they should wash their hands well with soap and water. Then they have to clean them out. So only they have to use one soap for one stroke. So that also you have to tell them, because they are using the same the soap for multiple strokes. So that way the patients will get cross infections, that may be next eye also infected from the infected eye. So that kind of things you have to educate the caregivers. Next, coming to the nose and the ear care, here also you have to, whenever you see a bed-bound patients, you have to check the ear and nose, because there is a chance of dirt accumulated behind the ear that can cause ulcers. So you have to check for that, and also you have to check the ear that wax. So if they have used the earwax, like if they not use, sorry, if they have a earwax there, they sometimes they will be complaining about the hearing problems, do sometimes pain. So if you have seen like that, you have to refer the patient to the ENT surgeon. And the next thing is you have to check the nose also. If they have a crust formation there, you have to clean that crust from the nose, because they don't know, they can use cotton tipped applicators, or they can use they can take sticks and they can wrap with the cotton on the top of that area, that they can also make that soft sticks. So our idea is to remove the if they have a crust, that secretions in the nose, especially the patient is on nasogastric tube feeding, we have to give a proper nose care to that patient. And coming to the care of hair, for a bed-bound patient, they need a hair care at least once in a week. So we have to educate the caregivers about how to do the hair care. So here you have to tell the caregivers about how to do the hair care. They don't know for about bound patients how to give the hair washing. So if they don't have a Macintosh, you can give a plastic. You can take a plastic sheet and they can give hair that wash with the help of a plastic sheet. And also whenever they whenever they do the hair wash, they have to pluck the ears and cover the eyes. If they don't they are not plug the ears well, that the thing is the water will goes inside and develop another problem. So they have to plug the ear always, and also they have to protect the eyes also. So this is also you have to train them. I have a video on this. If I have time, I'll show it to you. Then nail care, along with the bed bath, you have to do the nail care too. Here, if they are not otherwise, you have to soak the nails for 5 to 10 minutes with lukewarm water. That time the nails will be soft. Then you can cut the free edges of the nails. So you have to encourage the caregivers to provide a nail care. They how to do the. Usually the caregiver will be telling that the nails are hard and not soft, and they are not able to cut properly because of the thickness or hardness and all. So that time what we used to tell them is, you can soak the nails with lukewarm water 5 to 10 minutes. Then the nails will be the nails become soft and then they can easy to cut. So that way we can educate the caregivers. Coming to the bed bath, you have know why the bed bath is important. We have to maintain and promote hygiene. If you give a bed bath, definitely we can able to promote hygiene. So here I also so one or two important points I'll highlight. I'm going to highlight few important points because we all know how to do the bed bath and all. Here, the one important thing is always they have to maintain privacy. So, in the home, the houses also they should maintain a privacy, and also they should also expose the small what area they will only the small area of the body should be exposed at a that bath at a time. So that important that message you have to convey with the caregivers. Otherwise, they what usually do they remove all the dress from the body, so that create lot of that problems. They feel guilty and they feel very anxious about somebody's came inside, and that kind of anxiety will be there. So this is very important. You have to tell the caregivers about they have to expose only the area which they need to clean that at a time. So then they should protect that area with a towel or a bath towel. Then they have to expose the another area. And so after the cleaning that part, they should remove all the soap from that area. So otherwise, dryness will be there. And whenever they cleaning, they have to clean the cleanest area first, and then go into the least cleanest area. So we know the upper part of the body, like head, face, neck, eyes, neck, upper limbs, and chest, abdominal area is considered as a cleanest area, the cleanest area, and lower part we consider as a least cleanest area. So you have to tell the patient caregivers about they should clean the upper area first and cleanest area first, and then go to the that least cleanest area. After massaging, they should give they should apply moisturizing cream, and also they should give a back care at the time of the bed bath. So whenever they turn the patients from a supine position to sideline position, they have to give a special attention on the pressure points, and they can check whether there is any color change on that pressure points. If they have a color change, we need to give a special attention on that area and give a further pressure, protect the area from further pressure, so that way we can able to prevent that skin peeling and all. So also you have to, after giving back care, you have to apply moisturizing cream and provide a good massage. So that way we can able to improve the blood circulation, and we can prevent the threats of formation also. Now, on a few said like immobility can cause that one of the health complication like contractures. So if they are able to do that exercise, you can encourage the patient to do it their own. But if they are not able to do the exercise, you can encourage the caregivers to do the exercise. So if you do the exercise properly, we can prevent contractures, foot drop, and wrist drop. So all joints needs physiotherapy. So you can empower. So without the caregiver support, we can't do anything. For a bedbound patient, they need to. They will be there around for every days and all. Maybe once in a week or twice a week, we can able to see that patients, these kind of patients. So our aim is to through the help of caregivers, the patient will get they put there. So we need to educate and empower the caregivers about active and passive exercise. Coming to the catheterization part, we all know that what is catheterization? What are the types of catheterization which you have seen in your settings? Any idea? Oh, sorry. So here, these are the type of catheterization that indwelling catheterization. The first one is indwelling catheterization, which for indwelling catheterization we use Foley's catheter and the silicone catheter. What are the difference between Foley's catheter and silicone catheter? Is there any difference?
Silicone catheter we can use for a long time.
Okay,
Not
long time means?
ma'am, maybe for 1 year.
For 1 year?
Yes, ma'am.
Okay. How many of you agree? Salome said no, it's for 3 months.
Okay.
Okay. Then any other answers? Why you are saying like silicone catheter is long lasting? We can keep it for 3 months. So latex catheter is Foley's catheter is made up of latex. We can keep it for 4 weeks. After that, we need to change. Any difference? Why the silicone 3 months? Why latex 4 weeks? Sometimes the patients will ask you, sister, tell me, what is the difference between silicone catheter and Foley's catheter? The doctor asked me to put silicone catheter. What is the difference between these two? Then how will you manage? What kind of that education, explanation you will give to the patient and caregivers about that? So silicone, the catheter is made up of silicone. That is tissue friendly and less chance of infection. So that is why we keep 3 months. Okay, up to 3 months, it will not that maybe create such much problems. But in latex material like Foley's catheter, it will develop bacterial colonization happen within 4 weeks and develop urinary tract infection after 4 weeks. So we need to change every 4 weeks. So here in indwelling catheterization, indwelling suprapubic catheterization, if they have any problem in that urethral canal, we used to do that surgeon will make a hole in the suprapubic region and insert the catheter into the bladder straight away. So that is called suprapubic catheterization. Then clean intermittent self catheterization. If the patient is, we used to do use in labor room. Usually that time we used to use Nel cath. So here for a paraplegic patients, we used to train the care patient. If once the bowel, once the bladder will get develop, they maybe get they'll develop pincher sensation like things. We educate the patient about how self-intermittent self-catheterization. So we have a lot of patients to do the clean intermittent self-catheterization. And now last one is contact catheterization. So this is how this picture you have seen. One is Foley's catheterization and the another one is suprapubic catheterization. When the suprapubic catheterization, we can made a that surgeon will made a hole into the suprapubic area, and that way we can able to insert a tube, that Foley's catheter, into the bladder and to drain the urine straight away from the bladder. And the another one is Foley's catheterization. So here we all know this procedure we should do the aseptic. We should maintain an aseptic technique because this is one of the foreign body which we have to insert into the bladder, because that can cause urinary tract infection if you are not taking care of properly. There is a chance to develop urinary tract infection. So whenever you insert, one of the trained persons only will insert a Foley's catheter into the patient. So you have to maintain a aseptic technique. Choose the smallest size as much as possible. Choose 14 size for male persons. Usually we used to use 16 size for female patients. And also we all know that we have to lubricate the tube well. But here one major difference is male urethra is longer than the female urethra, but your the lubrication is not enough for a male catheterization. But that time what we can do here is we in the silocaine jelly itself there is a small nozzle there. We will open the silocaine jelly and connect that nozzle and push that silocaine jelly into the, after cleaning that perineal that area. So after cleaning with antiseptic solution, of course for a male patients you have to retract the foreskin and clean that area with antiseptic solution, and then you have to introduce silocaine jelly into the urethra. You have to push that whole jelly into the urethra, because the urethra is too long. Wait for another 2 to 10 minutes. Then that time the whole canal will get some kind of anesthetic effect. Then after that you have to insert the Foley's catheter. So that way we can able to prevent irritation sign pain. Okay, so before inflating the bulb, you have to make sure that whether the tube is inside the bladder or not. So how will you make sure that tube is inside the bladder? How will you make sure there are tube is inside the bladder?
The urine is coming out.
Yes, very good. So whenever the urine is coming out, we have to we understand that okay, the tube is inside the bladder. Okay, so then only you have to inflate. So how much water usually will take for inflation?
8 to 10 ml.
10 ml. So
Yes,
how many
ma'am.
of you agree with that? 10 ml? All of you? 5 to 15 ml? Usually 10 ml, 10 to 14 ml. Okay. So if you, if you have taken more than 20 ml, what happened? Is there any problem? So Kaditra said if you have seen that catheter and the that two thing the bifurcation to that part, it will write wrote like 30 to 50 ml like that. It may burst. Shiha said it may burst. Not Shiha. Yeah, that 30 to 50 ml capacity is there in that that catheter bulb. Any other problem? So the thing is, if you inflate too much, more than 10 ml, it will irritate. It will irritate the bladder wall. That thing is bladder, that mucosa, and develop bladder spasm. So that is the problem. See, if you inflate more than that 10 ml, it will touch the bladder mucosa or bladder muscle and create bladder spasm. So our why we are inflating that bud? The thing is, we need to keep the catheter for 3 months or 4 weeks. So 10 ml is enough. If you inflate, if you use 10 ml, the bulb size is like this. Okay, so this much that bulb is inside the bladder. So 10 ml is enough. If you give more than 10 ml, it will definitely develop bladder spasm. So at least if you have seen a few patients after inflation, they will tell you some distress, pain. I have seen many patients like that. So after inflations, that the patients like if you use more than 10 ml, 20 ml like that, the patients will tell you, oh my God, I have such problem. Why are you doing like that? So what you would insert inside my bladder? That kind of questions will be there. So maybe because of the bladder spasm. So you can use 10 ml. And also antibiotic prophylaxis. Before we used to give antibiotics for each after each insertion of that catheter. So nowadays it is not recommended. If there is any urinary signs and symptoms of urinary tract infection there, then you can take a maybe you can take a culture for urine and send the urine for culture and sensitivity test, and then if they need, you can give antibiotics. So otherwise it will not recommend it. Coming to the clean intermittent catheterization, always you have to maintain privacy. Wash hands if they ask. I mentioned earlier, if usually the paraplegic patients, if they are willing to put a self intermittent catheterization, we used to tell the educate the care patient about to insert that self intermittent catheter NELCAT into their bladder, because we usually use a 12 French size that NELCAT, and before you have to tell if they are willing to put self intermittent catheterization, you have to tell 3 things. They have to wash their hands with soap and water before and after. That is the one important thing. So, and the another thing is they have to lubricate the NELCAT with silocaine jelly before insertion. And the third one is they have to do it every 4 hours. Okay, so what we do here is we used to give 4 numbers of NELCAT in a day first, and then The first Nelker they can use in the morning 6 o'clock. Then the next one they after use they have to clean under running water and keep it in a clean tray. And then next the 10 o'clock they have to use the new thing, and that can also they have to clean. After that they have to clean under running water and keep it in the, they have to mark it 1 2 3 for like that. So that way they have to maybe they can use every 4 hours, that kind of things they will be following here. And after that, here if they have used, there are a lot of advantages, because it will not produce too much urinary tract infection, because they will be inserting in directly into the bladder and straight away drain the urine, and they will remove it back. So that there is no chance to develop urinary tract infection, and we can able to improve the quality of life, because imagine a young that 24-year-old man or 30-year-old man who's having Foley's catheterization because of paraplegia. But once they sense, they are able to sense their bladder that capacity, like bladder sphincter and all, we can able to don't need to continue the patient with Foley's catheterization. We can remove it, and we can remove the Foley's catheter and try this way for emptying the bladder, and they can. We can able to give a that self-esteem, and they can maybe their confidence level will be improving, and easy to use, expensive also. As I mentioned earlier, reduce the risk of infection, and we can able to improve sexual life too. So coming to the quantum catheterization, here also, this is the external device, okay? So no need to insert in the bladder. Usually, if a patient is on intermittent catheterization, we suggest quantum catheterization for the night time. So, so that they can, they won't they will not able to, maybe they were not able to get maybe wake up during the sleeping time. So if they are using even if they are using intermittent catheterization for the daytime, it would be better, but during the night time they can use quantum catheter. And here some advantages and disadvantages is also there. So here also less catheter associated urinary tract infection, more comfortable than endolytic catheter, we all know that, and less movement restrictions. Whenever wherever they can go, they can go, and less movement restriction, and non-invasive also. Here some disadvantages is leak. There is a chance of leakage sometimes. Skin irritations will be there because of the material, and more likely to fall, and allergic reaction too. So these are the disadvantages of quantum catheterization. So here is a case scenario. Can anyone please read this case scenario? One of you can read, please.
I will read them.
The home care unit of the hospital made a visit and found that the patient was having pericatheter leak. So they changed the catheter. The next day, the carer noticed that the pericatheter leak was still persisting. She called them again. They came and changed the catheter. Again, the next day, the same happened. Once again, the catheter was changed. The catheter was changed 3 times, but the problem did not resolve.
So what could be the cause? Any idea?
Ma'am, overactive bladder, maybe.
Overactive bladder. Okay. Then Mahima said urinary tract infection. Then any other problem? Salome said small size of the catheter. Then Any other things? So here pericatheter leak is the problem. The catheter was changed 3 times. They have changed the size also, but the problem did not solve. Impacted stool. So that is a very good point Mahima said. So this is, here is a fecal impaction. Constipation is the problem. If there is a constipation there is a problem. So what happened is, if there is a fecal impaction there, that will be compressing the neck of the bladder. So that way the urine will not be able to coming out freely. So that time the bladder will push out the urine, and that through the urethra the urine will come out. That okay, some sort of pericatheter catheter leakage will be there. And the another thing is, here is the fecal infection. So as one of you mentioned earlier, if there is an infection there is a chance of pericatheter leak. Okay, and the another thing is bulb size. So that overinflation of bulb can cause pericatheter leakage. So these are the 3 common cause. One is infection, then the second thing is fecal infection, the third thing is overinflation of bulb. So if whenever the patient is complaining of pericatheter leakage, you have to identify the cause first, to say how why they develop that pericatheter leakage. You have to try to identify the cause first and then try to solve the cause. So you have to coming to the bladder care, the catheter should be changed every 3 weeks to 1 month. If they are using Foley's catheter, they should remove every the 3 weeks to 1 month, and provide perineal care. So we have to tell the caregivers about the importance of perineal care. If they are able to do the perineal care, they have to clean from the umbilicus to the mid-thigh with soap and water. And always they have to keep the urobag always closed and below the waist level. So after empty the bag when it is 3/4 of full or half full. So here intake of fluid. This is very, very important in bladder care. All other things is also important, but as I mentioned earlier, if you insert a Foley's catheter into the bladder, it is a foreign body. There is a chance of developing urinary tract infection. So we have to educate the patient to take plenty of foreign fluids. So we can able to prevent urinary tract infection that way. And the second thing is perineal care. Perineal care is very, very important. With soap and water, they have to clean that perineal area with soap and water. If for a male patient, they have to retract the foreskin and clean that area with soap and water. And bowel management is also very, very important. They have to make sure that their bowel is moved freely. Otherwise, if they have developed pericatheter leakage and other urinary tract infection too. If they have a constipation, there is a chance of developing urinary tract infections too. So we have to encourage the patient about a daily movement too. So coming to the care of perineum, here also after each urination and defecation, especially for a female patient, they have to clean the perineal area with soap and water at least 3 to 4 times a day. They have to clean it and dry from the cleanest area to the least cleanest area. And they have to clean their hands after giving perineal area. So perineal care. So you have to give that things education too. And coming to the bowel care, for a bed-bound patients, due to lack of exercise, privacy, and reduced food medications, these can cause constipations. So immobility can cause constipation. Privacy can cause, if you are not giving proper privacy, how they can pass through. So if you imagine, if you put a come out in that open area and ask the patient to pass to. So they will not pass. So we have to give a proper privacy to the patient, and if they have a reduced food intake there, maybe develop constipation. Medications, most of the medications can cause constipation. Example, opioids, morphine can, one of the common side effect of morphine is constipation. So these are the things we have to assess and encourage the patient for bowel movement daily. Patient should be encouraged to take a high fiber diet and adequate fluid intake. You have to educate the non-pharmacological management, and then if that not help, you have to, then you can think about the pharmacological management. And you can use wet pants. If you are, even if you are using wet pants, you have to give a privacy, and you can give a adequate time for defecating, for defecation. So here last is spurious diarrhea. We had this word in the gastrointestinal the sessions. What is spurious diarrhea? Spurious diarrhea or overflow diarrhea. We have learned in the gastrointestinal symptoms in constipations session. We have learned. So this is very, very important. What is that? Any idea? Contaminated with stool. Any other answers? So usually after a period of constipation, the caregivers will tell you like yesterday or day before yesterday onwards, the patient start the fluid pass. The patient was starting passing like a few fluid, like few fecal matters. So we thought like, okay, patients, the caregivers, what they thing was the patients developed diarrhea. So here, because of the chronic constipations, that upper bowel, that fecal matter is obstructed into the upper part of the bowel. So because of the bacterial colonies, that bacterial action, the fecal, that watery stools leaking from the side wall of the intestine and presented as a diarrhea. So the caregivers will be thinking like maybe diarrhea. So it will not diarrhea. Not like a diarrhea. It is a serious diarrhea after a period of chronic constipation. If they have a history of like this, you have to ask the patient about the bowel history, and when they are last bowel mode, and then are they satisfactory, the quantity, that kind of things you have to ask them, and do a PRE, per rectal examination, and find out if they have a spurious diarrhea. If the fecal matter is obstructed in the upper bowel, you will not felt any usually the rectal mucosa. Usually when you insert your finger into the rectum, like if you do the PRE, you can able to touch the rectal mucosa. But in case of spurious diarrhea patients or overflow diarrhea patients, you can feel the balloony space. So balloony space, you are not able to feel the rectal mucosa. So how you can manage that kind of situation is, you have to that if the fecal matter is there, you have to remove manually. Otherwise, you can give a high phosphate enema. High phosphate enema means you can insert a suction catheter into the rectum, and as much as possible you have to insert, and then you can give at the end. Then you can give 1 or 2 sodium phosphate enema at a time. So while you insert the suction catheter into the rectum, so that the suction catheter tip, your suction catheter tip goes in the upper part of the obstructed area. So when you push that sodium phosphate enema in through that tube, that sodium phosphate enema will goes up to that area and will act from there. So that way that the fecal that the constipations will relieve. So we have a video on catheter care. Then we can watch on that and then. Was what is nasogastric tube feeding. Here, whenever you feed an nasogastric feed, you give the semi-fowler's position at least. While giving feeding, you have to prevent air entry, and also before giving that feeding, you have to make sure that whether the tube is insert the stomach or not. You have to aspirate the stomach contents and find out if the stomach contents is more than 50 ml. You can skip the feed and then you can next feed you can give. And the next thing is they have to grind the whatever they have, they can give. Before that, they have to thoroughly grind it and filtered. Otherwise, it will cause obstruction. And every 2 to 4, every 2 only they can feed, not more than 250 ml. So they can keep 50 ml for that before and after. Maybe 25 ml they can give for before feeding, and after feeding they can give another 25 ml of feeding. That is, they can that way we can able to give up to give it to 250 ml at a time. So 200 ml is the prepared feed and 50 ml for that 25 ml before and 25 ml after. So total is 250 ml. So keep the patient the same position at least 30 minutes. Why? So that is one last questions to you about why we need to keep the same position at least 30 minutes after feeding. Any idea? Danger of aspiration, Salome said. Why this patient? Okay, to prevent?
From aspiration.
Aspiration, okay. Why these patients get aspirated?
If regurgitation will occur then.
Okay, if regurgitation, normal persons also regurgitation occur, no? What is the anatomical changes happen here? If you insert a nasogastric tube, what is happening here? The catheter blocks the sphincter. Is that block? So here you have to see that we have a nasogastric. This is the nasogastric tube, no? So we have a gastroesophageal sphincter here. So when we insert an nasogastric tube, the gastroesophageal sphincter is always open. Okay, so here even if the sphincter is that start to close, but because of the tube, that it may not close well. So that time, what happened is when the patient is regurgitated, that easily goes up and the patients will get aspirated. So that is why we tell before feeding they have to give a semi-fowler's position, and after feeding also they have to maintain a same position at least for 30 to 1 hour. So otherwise it can cause aspiration. So you have to tell the caregivers about the importance of this. And oral care is also important. This is often neglected if the patient is on nasogastric tube. This is also important. Oral care every 4 hours only. Whenever they give a feeding, they have to give a oral care also. And change the adhesive tape is also important because there is a chance of ulcer formation. They have to fix it on the bridge of the nose, either right side of the cheek or left side of the cheek. They have to change the tape. that whenever, maybe at least once in a week. So we have another video, a 3 minutes video on nasogastric tube feeding. Then I'll take a few questions if you have.
Tube feeding. Nasogastric feeding is given to the patient who is not
Doubts or any clarification? Is that any, if you have any doubts?
I can also say it directly. The container for intermittent catheter shouldn't be a closed plastic container because the catheter needs to dry off. So what we sometimes use is a clean sock and, or cotton bags.
Okay, cotton bags. Okay. Any other things? This is your last day. Anything you want to share